Yeah, Girish, I've restarted without authentication, so everybody should be able to rejoin. Good morning, Sri Vikram Pagaria. Welcome. Thank you for joining us. We'll just wait for all the participants to come back and start. Girish, you please take over from here. Thank you so much.
So you tell me when to start.
We have about 30 participants already on board, and all the panelists are on board.
Are we good to go?
Maybe just a couple of minutes more.
Couple of minutes, yeah.
Yeah, a couple of minutes more. Because we had to rejoin, right? So people are just coming back. Yeah. So much for cybersecurity. I didn't want people to come in without authentication, and we got into this issue a little bit. Yeah.
Yeah. Hi, Vikram. Our discussion is pending long time.
Right. Well, I think Girish, you could start because we have about 41 attendees already and 8 of us. So I think it's a good quorum. We could always have people joining in as the talk progresses.
Fine.
Yeah. Thank you.
So good morning, one and all. So we are conducting this survey in collaboration with HCHC, that is Bharat's initiative on the topic Ayushman Bharat Digital Mission. It's the most sort of discussed topic in most of the panel discussions, webinars, etc., where we have the person itself from NHA, Mr. Vikram Pagaria, to discuss. See, the main intent of this study, which was conducted, was a lot of things being talked about ABDM in implementation. People have a lot of queries, a lot of roadblocks, misunderstanding what is ABDM, how to go about it, etc., etc. And also the other factor in ABDM is how prepared is a hospital for ABDM. So what is the digital roadmap of the hospital? So unless there's a good digital roadmap, ABDM would not be possible to be implemented. So in this context, we spoke to a lot of hospital CIOs pan India to understand where are they on the ABDM? Are they talking to their HIS vendors? Because HIS vendor is one of the key stakeholder in the ABDM implementation. And also on what do they see as a IT department post-COVID? Are their budgets increasing, decreasing? What digital initiatives have been taking so far, etc., etc. So let me have the pleasure of introducing the panelists. From CHiME side, we have Arvind Shivaramakrishnan. No need to introduce him. He is the secretary for CHiME. And also Mr. Girish Kulkarni. He is the chairperson from CHiME India. With us, as I mentioned, Mr. Vikram Pagaria. He's the joint director for the NHA, an alumni of IIT Kanpur. He has done his master's in public health from Harvard. And since 2010, he's been an IRS officer also. So, warm welcome, Mr. Vikram Pagaria. Then we have Mr. Bharat Gera, who has been also needs no introduction. He has been in the healthcare ecosystem for more than 20 years. He has been wearing various hats, like he's been an entrepreneur, consulting CIO. Now he's formed his own company that is Human Centric Healthcare Ecosystem. With him, his team is also there. Joyoti Goswami, and she's also in this space for more than 25 years. She's worked with various projects across the globe. Currently, she's working with Demo Consulting on digital initiatives also. And we have Dr. Sita also, who was a part of this team, and Rhea Singh from NHA. So all yours, Bharat, and let us know what were the expectations from the people who have the survey, any questions, and what were the findings, and you can take it over from here. Thank you.
Thank you so much for the introduction, Girish. I think on the request of Shri Pagaria, I think we'll start with the session on ABDM first, and we'll then follow it up with the study findings. So I request Shri Pagaria to start his presentation. Sir, will you be doing the presentation, or will Rhea be taking the host control?
Rhea should do the presentation. I'll just...
Okay, I will make you the host, Rhea, so you can take over and share the slides.
Sure. Before I do that, would just open the room for Vikram sir in case any opening comments from your end before I take the group forward with the short presentation on ABDM.
Yeah, I mean, I would like to thank CHiME and CHCIO for undertaking this study. When Manisha ma'am reached out to us saying that something like this is going on and would we be able to participate, I think we are very happy that we have been involved, and the group is taking conscious efforts to understand ABDM, to think loudly about it. In NHA also, there has been in the recent past a lot of focus on as to how do we how do we make efforts to increase the adoption of ABDM, particularly the adoption of ABDM in the private sector has been a challenge. We have come up with an incentive scheme. We have come up with different initiatives like the microsite, the scan and share, some of which Rhea will mention. But I'm sure there is a lot to be done by NHA, and we really look forward to receiving input, suggestions, comments, candid comments about ABDM, and let us all take this further, because in a country like India, we'll never have a doctor sitting in each village. It has to be technology that would provide healthcare, that would help in providing affordable, accessible, and quality healthcare to our citizens. So we'll just request Rhea to run a small presentation, because it was mentioned in the beginning also that there are a lot of misconceptions, a lot of things which need more clarity. So Rhea works closely on adoption of ABDM. After the presentation, if there are any questions, we would be there, and we look forward to hearing more about the study. So over to you, Rhea, and once again, welcome everybody.
Thank you. On behalf of CHiME and CHCIO, I'd really like to thank you for coming in at such a short notice. Really appreciate it. Thank you so much.
Great. Thank you. Thank you, sir. Thank you to the CHiME team for having me as well. I am going to share my screen. Just allow me a minute. But as I do that, I think just a quick background about me as well. As Vikram sir mentioned, I've been with NHA for over a year now, working very closely with Vikram Pagaria sir's team and working on integration and adoption of ABDM. So how, as I understand, majority of the participants here are folks from hospitals, various physicians as well, who want to understand more about ABDM and how they can join the ecosystem. So keeping that in mind, I've divided the presentation broadly in two bits. One is, I think, just a quick understanding of what ABDM really is, right? Bust any myths, questions that there may be about ABDM, its architecture, and how this ecosystem is really evolving. And the second bit is actually how can everybody join the ecosystem? So for everyone who is present here, again, whether they're a practicing physician or they have their own HMIS or so on and so forth, how can they integrate their platforms with the ABDM ecosystem and really join the journey on digitizing healthcare in the country, right? Bharat sir, I don't know how we're doing. Should we take questions at the end, or should we open questions in the middle as well? However you suggest, we can
take it at the end after the
Sure,
presentation.
sure, right. Yeah, so just a quick background about ABDM, right? I mean, I think ABDM, erstwhile NDHM, right? National Digital Health Mission, it was called a couple of years ago, was envisaged really to build a digital health ecosystem that supports universal health coverage. in the country. And this was grounded very, very solidly in technological and policy principles, right? So can we build single source of truths in digital healthcare? Can we have an infrastructure that in healthcare that is a federated architecture? So there's ensuring that there is confidentiality, security, privacy of data as well. Can we build an ecosystem that is based on open APIs and enables interoperability? So those are bits from a technology side. And from a policy standpoint, we've kept the ecosystem as user inclusive as possible. We want people from every corner of the country, every start of the society to be able to participate in the ecosystem. So it's very user inclusive. It's voluntary in participation as of today. We want people to be aware of ABDM themselves and join the ecosystem and leverage the benefits of it. And lastly, I think the intention really is that can we move towards an ecosystem that is more wellness centric? So can we move away from reactive care to actually preventive care, and how can ABDM really support this vision at large? So this is just a quick journey of how ABDM has evolved. So the thinking behind it started pretty much from 2017, where there was a document on national health policy that came out. Then we had the national health stack that came out in 2018, and then the national digital health blueprint that came out in 2019. These papers came out, from NITI Aayog, from the Ministry of Health and Family Welfare themselves, culminating in the NDHB, the National Digital Health Blueprint, as we call it, with support of NHA. That really becomes our Bible on what the ABDM ecosystem is really built on. And all of these documents are available on public domain. So we'll definitely encourage everyone to go through these documentations if you'd love to know the more details and nuances of ABDM ecosystem at large. And I think post that, in 2020, the Honorable PM announced this as a pilot across 6 UTs. And for a year, a pilot was ran to actually understand the on-ground implementation and learnings, post which in 2021, it was launched nationwide for all states and UTs, for all healthcare practitioners, all health tech players, and all citizens to actually now join the ecosystem. In Feb 2022, happy to report that it was approved as a central scheme. And in September 2022, we actually finished a whole year, and we had a great event actually to commemorate the work that had been done in the first year itself. And as of today, where we stand, we're really focusing on, it's been live for over a year. How do we really drive its adoption in the long run? Now, what is ABDM, right? That is the key question that comes up very often. So before I get into the more technical, complicated slides, I just wanted to spend a minute on this, right? Just simplifying the concept. I think there are 4 key objectives that ABDM is trying to solve for by building the tech infrastructure, the digital infrastructure that is required to support digital healthcare in the country. So first of that is to build digital identities. So can we build digital identities of all actors who are in the healthcare ecosystem? So right from your citizens to healthcare facilities, healthcare professionals, as well as drugs. So can we build authenticated, verifiable identities for all of these actors in the ecosystem? So that is one aspect. Second is enabling interoperability and exchange of health data. So ABDM architecture allows for interoperability, meaning exchange of health data across various healthcare facilities, healthcare practitioners, to exchange data from one healthcare provider to another healthcare provider. So today, sharing data between 2 different hospitals becomes very, very difficult. We're carrying usually physical files, copies of our reports to share data. But through this architecture, it'll be possible to digitally exchange data across various stakeholders in the ecosystem. Third is the interoperability of health services. So how can we make services more accessible, more interoperable across various platforms? These services could include teleconsultation, booking physical appointments as well, discovering drugs, booking ambulances, discovering blood banks. So anything to do with health services, right? How do we really make those interoperability in the services aspect is what ABDM also enables for. And lastly is interoperability of health claims exchange. meaning, how can we standardize the claims process between a hospital and a provider and a payer, an insurance company, and how can we standardize that process, right? So just to recap, how can we build identities? How can we better exchange health data? How can we better enable interoperability of health services, and then the insurance piece. So largely, if you'll see, the entire journey of a citizen is really covered for, right from discovering a service to exchange of health data and then also filing for claims. So all of these aspects is what ABDM enables for, and the idea is really to that it will increase accessibility, efficiency, and transparency in the healthcare ecosystem. Now, the thing is that there are many, many challenges that currently everybody faces. For a citizen, it could be, can I check my medical records at one place? I'm getting services from many, many different hospitals or providers. Can I have all of that stored in one place? Can I share my health record data with my doctor with ease? Can I book health services? Can I order healthcare products online? Right. So all of these challenges that a citizen currently faces can be addressed by the ABDM ecosystem. And similarly, for a healthcare provider, it enables them to access and view a citizen's health history. It also enables them to participate more actively in teleconsultation. And then from a policy standpoint, saying, can we, at some point also think about how can we make data available at a national level, which is aggregated, anonymized, and that can really support decision-making and policy-making at a state or a central level. Now, I'll pause here for a second because I think this slide really encapsulates what ABDM is in a nutshell, right? So I think if you can just follow my cursor, if you can see that moving. This is the bottom layer, right? These are registries that I spoke of earlier as building identities. So ABHA, the Ayushman Bharat Health Account, which is an identity number for all citizens in the country. Healthcare Professionals Registry, which is a registry of all healthcare professionals in the country. Healthcare Facilities Registry, which is a registry of all healthcare facilities in the country, and Drugs Registry, a registry for all drugs in the country. So these 4 registries are being built under ABDM as digital public goods. So essentially, it will provide identity to all of these various actors in the ecosystem, as I spoke of. And interestingly enough, these are being built on top of some of the existing digital public goods that exist, such as Aadhaar or DigiLocker or eSign. So currently, your ABHA for a citizen is actually verified and authenticated using Aadhaar that is already out there in the public domain for everybody to use for accessing various services. That's the identity layer. Then we have the 3 gateway layer that I spoke of earlier, right? So the central bit, the gray box that you're seeing, is the Health Information Exchange Consent Manager. And just for simplicity's sake, just think of these as 3 gateways that exist that NHA has built and made it open to the public. What these gateways allow is really where the beauty of ABDM really lies, right? For the Health Information Exchange Consent Manager, this allows for that exchange of health data, right? So can we make health data sharing possible, collation of my data to maintain longitudinal health history, so on and so forth. So that exchange of data between 2 hospitals, 2 doctors, from a citizen to a doctor as well, all of that is possible via this gateway. So a request may be fired up from hospital A to access the data of a citizen that is routed via this gateway. And in the middle, the citizen gets consent saying, shall we share your data? This request has been made, and the citizen can give consent, and their data is shared from hospital B back with hospital A through this gateway. So that is the exchange of data bit. On the left-hand side that you'll see is a unified health interface. For simplicity's sake, you can think of this as the UPI of healthcare, right? So how with UPI, you can exchange money, transfer money across, from a Paytm to a Google Pay to a Phone Pay. So that interoperability of services has happened in the fintech sector. So a similar approach has been taken in the health sector as well, saying, can I be on one particular application, whether it could be a Practo, a Tata 1mg, eVital, so on and so forth, and my doctor may be using a different application, right? So how can we make people on 2 different platforms talk to one another is what UHI will enable. And when people are able to talk to each other across different applications, Things like teleconsultation will come into play, discovering labs, discovering pharmacies, booking appointments, bed discoverability as well, right? So all services will then kind of be available to a bigger, larger audience to access and avail through this gateway. And lastly is the health claims exchange bit. Like I mentioned earlier, this is the standardization of the claims process between a hospital and a provider. So it includes the e-claims process is standardized, the policy markup language is standardized, the bill markup language is standardized. And the idea really is to reduce the turnaround time for claims process. Can we have auto verification happen? It will drastically reduce the frauds and things of those nature during the claims process as well. So these are the three gateways that exist as part of the technology architecture of ABDM. And if I come last to the user application, right? These gateways exist as a technological backend that NHA has provided. But how does a citizen, how does a doctor really become a part of this ecosystem, right? So this is where the applications come into play. So for a citizen to be a part of an ecosystem, they may use a PHR application or a personal health record application. So any application that allows them to manage their health data better, share, discover health services better, so on and so forth, is what a citizen uses. For a doctor to become a part of it, they would need their HMIs or the LMIs or any other software that they're using to be integrated with ABDM so that they can carry out the functionalities that are part of the ABDM ecosystem. So I'll just pause here, just for everyone to just consume this slide. I know it's a heavy slide, but this really encapsulates the many possibilities that are there as part of the ABDM ecosystem. So we have the identity, the exchange of health data, exchange of health services, and then standardizing the claims process, right? So hoping that all of this will kind of contribute towards more transparency, better delivery of care, more customized care, and just more efficiency in the healthcare ecosystem. I mean, this is just a quick example, right? How can this really impact a citizen in a wonderful way? Where, we've taken an example of, you have a woman in her, who's 28 years old, who can manage her records on a PHR application. And look at her healthcare journey, right? She is pregnant. She's a beneficiary of the reproductive and child healthcare program. She is also availing services under IDSP. She's going to a government hospital. She has also gotten a COVID vaccine. And then perhaps she's also moving to a private hospital to get a private consultation done as well, right? So, and this is a reality that we're all facing, right? We are getting second consultations done very often. There are many crores of beneficiaries under each of these government programs. So how do we ensure that the person who's traversing the complexities of a healthcare ecosystem, can maintain their healthcare data at one place, right? I should be the owner of my own healthcare data. I should be able to manage my healthcare data that is coming from various devices, various platforms at one place. That is one. And second is I should also be able to present my identity to each of these service providers as well, saying, here is my Aadhaar number, which says this is my name, this is my demographic details, and that is actually verified and authenticated information of the citizen in the entire healthcare ecosystem. And again, at the bottom, you can see if patient provides consent, this data can also be accessible by their doctors, by their nurses, by their frontline workers, by insurance companies, with the consent of the patient themselves. I'll just quickly run through this. This is, the gateway that I spoke of earlier. So if any health information user, which could be a public program, a doctor, a health locker that wants to get healthcare data from a different hospital, they can usually, raise a request. The request is routed via the consent manager. It goes to the health information provider, which could be a different hospital, which then shares back the data with patient consent. This is UHI, just double clicking on Unified Health Interface. How today, like I mentioned, if you are on application A, your doctor also has to be on the same application for you to be able to talk to one another. But with UHI, what will be possible is you can be on one application, your doctor can be on a different application, and they can speak to one another And this is all fueled by open protocols, open APIs that NHA has built and supported and is now made available for everyone. Now, these are the 3-4 elements that we spoke of that ABDM fuels. I just want to take a minute and say, we've been live with ABDM for over a year, right? So where are we currently in the ecosystem? So these are just a few numbers to put the adoption into perspective. For example, with over 43 crore citizens today have their ABHA, the Ayushman Bharat Health Account, which means that they have a verified, authenticated identity in the healthcare ecosystem for themselves. And this number is also increasing at a very, very rapid pace. These numbers have come from many areas, which could be the COVID vaccine, could be various programs, which is a non-communicable disease program, RCH program, and also many private players as well, who have integrated with ABDM, private HMIS players, private personal health record application players, who have also offered their functionality to create ABHA to their users, through which so far 43 crore citizens have created ABHA. Over 2 lakh health facilities today are registered on healthcare facilities registry. 2 lakh healthcare professionals have registered on the HPR. And these are a combination of both public and private healthcare facilities. And similarly for professionals as well, combination of both public and private, and also is across the nature of medicine. So it includes both modern as well as traditional medicine as well. There have been over 23 lakh downloads of the health record application. So as part of the initiative to drive adoption, NHA has also built its own PHR application, which is called the ABHA application. It is available on Android right now, as well as iOS soon. So over 23 lakh citizens have downloaded this app and are actually using this to better manage their health data as well. So if you have an Android device, I would recommend, you may also download this application and see for yourself how you can manage your health data and also pass that information on to your patients. 28 crore health records have been linked. Now, what that means is 28 crore different health records that have been generated have been linked to the ABHA of a citizen, right? And that is how you really are building the longitudinal health history, that my health data is actually being linked to my identity number or my identity address. And that is what enables me to carry forward this data and share it across the ecosystem. We have 1,000+ active participants who are integrating with ABDM. I'll actually move to the next slide to talk about this. So currently the logos, the names that you're seeing on your screen are the various players in the ecosystem who are already part of the ABDM ecosystem. And like I said, we have a diversity of players who are part of the ecosystem. So we have government health programs, we have COVIN, NCD, NICSHARE, Poshan Abhiyan, RCH, right? And these are programs who have beneficiaries which really cover a big landscape in the country, crores of beneficiaries who are already part of the ecosystem. We have government health solutions, which such as eSanjeevani, eHospital, eShushrut, Arogya Setu, DigiLocker, even some state-specific HMISs, of West Bengal, Tamil Nadu, Andhra Pradesh. All of these state-specific HMISs have also integrated with ABDM. And then we have private players. So and this is again a combination of HMISs, LMISs, health lockers, personal health record applications, labs, diagnostics, etc. So you can see a couple of names here, some leading market players, right? We have Practo, PTM, Briefcase, SRL, Narayan Health, Plus91. All of these health tech players are already part of the ABDM ecosystem, and people we're engaging with on a daily basis to drive its adoption forward. I also just want to share this, and Vikram sir alluded to this earlier, that while these are all great benefits to have in the long term, can we actually demonstrate a short-term benefit, immediate benefit to solve for the patients? And we actually designed a use case which we call scan and share. It's been in the news very often recently, so you may have actually come across this, where we often notice in these public big hospitals, the queues are very long, are very time consuming, and frankly very distressing for the patient to stand in, and then for the hospital to manage as well. So what was built was that, can we enable the citizen, to really empower the citizen to share their health, to share the demographic details with the hospital digitally. And they get their token number for registration on their mobile application, right? So if it's for a citizen who has an Aadhaar number that is generated, they would take a personal health record application, and this could be any application, could be Briefcase, Practo, Paytm, etc. And they use this application, and there's a QR code, that's placed in the hospital, and everyone's now familiar with using QR codes. So they go scan, and they give consent, and their demographic details are shared with the hospital's HMIs. And in return, they get a token number for their OPD registration. And then there is a screen display that is there in the waiting area. So as in when I know, okay, my token number is 10. So whenever token number 10 goes, I go to the counter, and then I'm assigned the department that I'm supposed to go for. So this has really brought down the registration time almost from 50 minutes to an hour to like about 3 to 5 minutes for a patient, right? So in cumulatively, if you notice, there's been a lot of saving of time for patients and the facilities, and also just, I think, enhancing the patient experience when they're going to go avail healthcare service. Now, this is just one of the many use cases, and NH is already in the process of widening the scope of these use cases and solving for other challenges that are also a citizen faces while they're in the hospital. But happy to share that as of we have over 50,000 tech tokens that are being generated. So that means 50,000 users are actively using this functionality with their mobile phone to just scan and get the OPD registration done under 5 minutes. So that is the ABDM bit, and now I actually want to share saying what can you do to be a part of the ABDM ecosystem. And this really is a call to action to everybody who wants to join the ABDM ecosystem. Is that if you are part of a hospital, if you're a physician, if you're a physician, would definitely recommend, encourage to please go check out the healthcare professionals registry and get yourself onto the HPR database. And if you have a hospital, clinic of any kind, get that registered on the healthcare facilities registry as well. I'll be happy to share the links on the chat shortly, so you can directly go and check that out for yourself. But if you are an HMIS LMIS provider, or if you're a doctor who has an HMIS LMIS, would encourage you to go get your solution registered on the ABDM sandbox to actually integrate with ABDM. ABDM sandbox is actually nothing but a testing environment. It's a technological testing environment for any application to just test out the functionalities of a particular platform or a scheme that is running properly in, to actually take that to the live production environment. So NHA has set up an ABDM sandbox. So any solution or a program can go register themselves on the sandbox. There is a short form that you have to fill. Once that is approved, there's a testing process that happens. You get access to APIs that are published by NHA in the public domain. You consume those APIs in your software, in your system, and then you exit the sandbox. And then you become part of the ABDM ecosystem, and you start carrying out the ABDM functionalities that are possible. This is just a deep dive on what the process looks like. Like I mentioned, you can go register on the ABDM sandbox. It's a short form. Once there's an approval that is to be given by NHA, which is just a process that happens within 24 hours to 48 hours, you get an approval on the sandbox, and then you get access to APIs that are published by NHA, which the solution will then have to integrate. And there's very comprehensive, detailed documentation that is available. So, it's not a very challenging task in that sense to understand the entire workflows that need to be incorporated for the solution provider. Once that is done, there's a functional and a non-functional testing that is usually done. Once that is done, there is a security testing that has to be carried out. And certifications are required just to ensure that your application, which is integrating, is safe to host. And post that, another final demo is given to NHA, where a committee sits to give a final approval. And once that is done, you exit the sandbox and then you go live in production, and then you are part of the ABDM ecosystem, which means that you can actually create Aadhaar numbers for your beneficiary. You can facilitate exchange of health data for your citizens and patients, and then you can also pull health data sorry, you can pull health data as well to see data of your longitudinal health history of your patients and so on and so forth. So that's just a very
sorry for interrupting. We have almost 10 minutes about time. So if we can get into the question answers quickly, if possible.
That I will. Actually, this is pretty much this thing.
Thank you.
These are the last 2 slides that I have that I just want to say that NHA has also put down a lot of support mechanisms for everyone to come onto ABDM. We constantly are doing many workshops, awareness activities, so social media campaigns, so on and so forth, to drive awareness among citizens as well as doctors and health tech players. Like I said, we have a pretty seamless integration process on the ABDM sandbox. I'm so sorry. We have use cases such as scan and share that are already live in hundreds of hospitals in the country. We have microsites, which is essentially a great opportunity for hospitals and HMIs and LMIs players to actually become part of ABDM. There's been budgets allocated for this, and NHS put out guidelines for this as well. This is again in the public domain, so would encourage you to read up on this as well to demonstrate ABDM usability in a specific in a small geography. And lastly, which I think may interest everybody here, is there's also an incentive scheme. So if you are linking X number of records, if you're doing ABDM transaction, there's a financial reward that NHA provides to the hospital, to the solution that is being used in the hospital, to the PHR application as well. So far, I'm sure Vikram sir can also attest to this. We've been dispersing funds every month on a monthly basis to all players who are actively contributing the ABDM ecosystem. So make this a really financially viable and sustainable, and encourage people to join the ecosystem as well. Again, details of the exact monetary benefits, etc., is available on the website. Right, and with this, this is my last slide. These are the links. So I would encourage you to go to the www.abdm.gov.in to read up more about ABDM, and also the Sandbox website as well. And all the information you'll require will be there as well. So I will stop here. My apologies for running over time, but if we have time, I'm happy to take any questions going forward.
That was very insightful presentation, Rhea. Bharat, what we can do is we can just run through the study, and then we can take the questions. Because now let's see what's the perspective of the people who have actually answered to these questions.
Sure, but a few quick questions to Shri Pagaria. If there's some that have already come up. He's in fact been actively answering many of them during the discussion itself. So I think you've been typing a lot of the answers. So would you like to answer some questions that are there on the question and answer? And if any of the panelists have a question that we can take.
I've answered mostly everything. Right. Drug registry, I'll also type, but if there are any questions from the panelists, happy to answer.
Girish, you had a question, Girish Kulkarni.
Yeah, so I was primarily asking about the M1, M2, M3 levels. What do you actually mean when somebody says I'm M1 certified, I'm M2 certified, I've been compliant with M3? What does that actually mean for a hospital like us?
Excellent. So we use an acronym here, CLS. So create, link, and share. So if you do M1, you can create and verify ABHA. That is the first part. L means linking. So every health record that you create, if you can link it to the ABHA, that is the M2. And M3 is where you share the records. So create, link, share. M1 means that any patient comes to your hospital, you can, and you have a functionality on your software which would help him create his or her ABHA, or would verify, would be able to verify, you would be able to verify whether the ABHA is correct. If you are able to do that, then you are M1 certified. If you are M1 is, after you do M1, you do M2. M2 means that suppose in your software, the doctor writes a prescription or a lab report is generated. If you can tag it to that ABHA, then you are M2 certified. And what is the importance of tagging? so that if all records are tagged to an Abha, then irrespective of whichever hospital somebody goes, all their health records are which are tagged to one Abha would be together. And that is why that is what I think Rhea also showed it in the slide of one Rani Devi, which was through who had accessed multiple programs. And M3 is basically you are able to share and you are able to access. For example, if my previous records that are there, so the HMIS or the hospital software or the lab software, if it has the functionality to ask my consent, and if I say yes, then to show all the records on the doctor's keyboard or the doctor's computer, that is M3.
Yeah, Vikram, I have a follow-up question.
No, sure.
Well, before I ask questions, when you said M1, M2, M3, and IC certificates, it reminds me of my engineering first semester to fourth semester mathematics, marks on the mark sheet, which I might as well not speak much about anyways. But having said that, so let's say if an hospital wants to start this journey and they may not have the wherewithal, okay, be it in terms of the IT team or maybe from the operations perspective, they may not be able to put too many people, too much of resources. How can they come and approach NHA to support them? It could be a small 100-bed hospital. It could be a 1,000-bed hospital.
It's a very, very, very good question. So hospital, if the hospital has a software, so normally what happens is that the vendors approach. So there are a number of vendors who are there. So you can ask your vendor, please go to ABDM and become ABDM enabled. That would also create some demand. Many vendors tell us that the hospitals do not ask for an ABDM enabled version. If the hospital has their in-house software or they have their in-house HMIS that is there, then what they can do is they can at least do the M1 and M2 piece. So they can register on our sandbox. I think Rhea had mentioned it in the call to action slide. And Rhea, maybe you can also share the link of your presentation if it is on a Google Doc here for the benefit of others. And they can register on our sandbox and they would have to do some software development. And that software development, if M1 takes about 15 days, and M2 takes about 15 more days. So that if that software development is done, your hospital will become ABDM enabled. We have an integration support team here in NHA whose task is to support all the vendors, all the hospitals who want to get their software integrated. We have tried to make improve our documentation, improve our support team. And that is why when she showed there are about 110 people, 110 software which have integrated. So software means that if a software has been integrated, then wherever it is used in India, if suppose Practo is integrated with ABDM, so wherever Practo is used, you can use the ABDM enabled version. So if a hospital doesn't have any software, then they should go on our website and see any ABDM enabled software, and we also have a buy button there. So you can buy software from there. It will go to that to the link of the corresponding software. And we have also come up with a list with a feature while we purchase cars. So we don't know which car to purchase. So you can also compare 2 different or 3 different or 4 different software. So all the features of different software, different ABDM enabled software are listed there.
Thanks, Vikram.
I just
Last
wanted
question
to
from
add,
my side.
sorry, just to add to
go ahead,
point.
Rhea, go ahead. Then
I think just in the interest of everybody, I would also mention, because a lot of question that we get is the pricing, right? That's a huge barrier that we face in terms of costing of the solution itself. Happy to share that a lot of our ABDM integrated softwares are really offering competitive prices at very subsidized rates. Some are even offering free for a couple of initial years, so on and so forth. So definitely don't let that be a barrier, and please do check out the website, which you can compare and even see prices that are being offered. Just want to share that.
Sure.
Excellent.
Vikram Rehab, last question to you. If
Sure.
I come back and then ask you to do a little more detailed, maybe an hour and a half kind of a session to all our CHiME and Hospital Tech members, and if you can probably enable a few of us to support the community in terms of these initiatives, what we can do is we can trigger this within the community. We do their first level of queries and support and stuff like that. And then we fall back upon to you, to your team for taking this forward as appropriate. So I would want to explore that and see if we can set up something like that, and then come back to you and then request you for your time sometime next month to do a little longer session, which I presume would be of interest to most of the people who are there on the webinar and many of them who may not be here.
We know that awareness of ABDM is a challenge, and we also want to partner with anybody who wants to know more about it. So it is something which we would be very interested in. Yeah.
Vikram, also from your perspective, and not for now but later, if you see certain things that we as the CHiME community can help with in terms of, and I know Rhea was mentioning a few things, but if you can start getting to specifics as to how as a community we can add a little more momentum and a thrust to the initiative. And while you didn't say it explicitly, but probably I'll take the liberty of saying it, there are more misconceptions than actually reality. So if you can sound us as CHiME Singh, and we can help in terms of trying to soft pedal some of these misconceptions so that people are more aware of it in terms of what to, how to, and also fears and misconceptions around possible repercussions, which actually are none other than a greater good for the whole healthcare delivery community. So if you can, think about that, we as CHiME would be happy to, chat with you and take it forward in terms of how we can engage constructively the larger community.
Absolutely. And two things that come to my mind immediately is that action happens only when you know about something and then you convert that awareness and your intention into action. So first you have to be aware. So we know that if we can partner with you, it would help in at least disseminating what ABDM truly is. I have been here since 2 months, but frankly speaking, in May 2021, when I joined, till August 2021, I was not able to figure out as to why there is a separate concept or a different concept for a health ID, why we are not able to use Aadhaar. So there are a lot of things that are really technical or really, you say, which is slightly counterintuitive also, but definitely it needs more discussion. And second thing is that what is the value proposition of ABDM? Right now also patients are taking their polythene bags and going to the hospitals. Healthcare is being done. It's not something which is very urgent or which is solving some of the most critical problems if you do not go digital. Still healthcare is being provided. So what else can we do? Or Rhea mentioned about scan and share, but we would also like to work alongside you, since you are at the helm of digital health, as to what more can be done, what similar things can be done in like scan and share. Scan and share is for the public sector. In private sector, there may not be queues. So if we can work together to brainstorm as to what can be some of the use cases or how should we take it forward, we would be happy to partner.
Just to add to Arvind's this thing, so misconception is due to lack of awareness. So once we have this awareness created, I think most of the misconceptions will disappear and we will be on a faster track.
Absolutely.
Thank you, Girish. I think this is the right time to segue into the study presentation, because we'll actually get to hear what the voices are on these
now
topics.
let's see what's the reality as of now. Yeah, Bharat, all
Right.
yours. You can just
Thank you. Just on the side of, as an individual, I always say, that's why I call it Human Centric Healthcare System. So it should always begin with oneself. I was one of the earliest people to install the ABBA app and also get the ABBA ID. And I went through various versions of it. So now I have 3 ABBA IDs, right? And no records, not a single record. So I think that's where the litmus test is. If we as individuals can use this effectively, only then we can evangelize. I think, and then, we run hospitals, so we can go to our influential people and say that, I want to see my records on this. I think that's where the real thing will happen. It's my view on that. But let's go on with the presentation of the study. I have my colleague Sita. I'm going to hand it over to her to start the presentation, and Joyoti will be the ones.
Can you hear Bharat? Did we lose it? Yeah.
We can hear you. Please go ahead.
Yeah, you are.
Set host.
Bharat, we can't hear you.
Oh, I was on mute, is it?
You were speaking on mute. Yeah.
Okay. All right.
I hope the screen is visible.
Yes, visible.
It's visible.
Yeah.
Bharat, are you speaking? Yeah.
Yeah, please go ahead. Joyoti, please start. Yeah.
We didn't hear you, Bharat.
They are on mute.
Yeah, let me start with the first few slides to introduce the topic. Yeah. So why we did this study, and we thank CHiME India for supporting us in this initiative. We were trying to start this from October last year, but there were several stops and starts before we really got going. But the objective here was that unless the Indian hospitals are ready for ABDM, things are not going to progress. As I was just saying before, I don't know if it was on mute, but what I was saying was that I had one of the earliest people to go for an ABBA ID, and then now I've ended up with 3 ABBA IDs with no records. And why are there no records? Because there are no hospitals which I can get the records from, or labs that I can get the records from. So I'm just waiting for these people to come on board. But then, this was a curiosity we had at CHE, that how prepared are they? Is there a hesitation? What is blocking hospitals from coming on board and sharing data with patients? So we decided to take up the study, and we were, very happy, and thanks once again to CHiME for giving us the support. So we've got a very, very small team, but let me introduce the team to you. Joyoti, who's leading the study, and she's got over 2 decades of experience in healthcare. She's working with the US healthcare system, not with the Indian healthcare system. She's been working with a firm called Damo Consulting, but she volunteered with HCHE to do this as a community member of the Indian ecosystem. And she wanted to also in the process learn about the Indian healthcare system. So it's been a great thing, to a win-win. We're getting some knowledge from how the US healthcare works and the Indian scenario. So thank you, Dr. Joyoti, for joining us on this study. And we have Dr. Sita Lakshmi. She is a young IHMR graduate, and she's been supporting us with her skills in research and Power BI. So all the reports have been done using Power BI, and she's come up with some really interesting reports, and we will be presenting those. Let me just go to the framework that we had set up. So when we were looking at how to evaluate the preparedness, we looked at various papers around how to evaluate the hospitals on preparedness. So what we came up with a 6-dimension model, which basically one is we included ABDM itself, the status on ABDM. Are they using if they're using a compliant certified ABDM product, then they have the highest stage. What is the leadership commitment? What is the technology readiness? So we didn't want to look at only one aspect, because what we believe is that hospitals that are ready for the digital health ecosystem would also have other dimensions besides technology. They'll be willing to innovate, they'll be willing to collaborate, they'll be able to improve on patient centricity. Because the heart of digital is about all these things. So the other dimensions are about the digital mindset. And we also wanted to see if the hospital's leadership is ready, because that's very important, because unless the budgets are allocated, things won't go forward. So we've done this study and we've got about 50 responses from leading hospitals. We've restricted the survey responses from 1 person per hospital. What we are trying to say here is we have very initial insights. We would like to dig deeper. We would like to get higher coverage of respondents, but we thought we were ready to present now with whatever insights we have, because I think some of these will answer the questions that were being put across, that what are the misconceptions, what are the current good and bad understanding of ABDM, and also about the digital health ecosystem. So I'll stop here. Over to you, Joyoti. Why don't you start our findings and present? Thank you.
Yeah. Thank you, Bharat, for this opportunity, and also thanks to CHiME once again. We start with the demography of people who have responded to our survey. Like Bharat said, we have around 48 responses from all over the country, but most of our respondents have been our CHiME members. So which is why you see a dense response in southern and western India, because this is where our CHiME members are from. And the responses have been from the CXOs and IT leads of the hospitals. Most of these hospitals are NABH or NABL accredited. So that is a good thing. And one of the conditions that we had laid forward is that they have to have an HIS to be eligible to participate in the survey. They have to have an HIS, and they should be a minimum 100-bedded hospitals. So like you see, we have very few hospitals, around 20% who are less than 250 beds, and we have a good chunk who are 1,000 bed plus. Majority of the number of beds we have are around, so 30% between 250 and 1,000 beds. And so a good chunk of them are having more than 1,000 OPD patients per day. Almost 45% of our respondents have 1,000 patients per day. And they are all, 50% of them, more than 50% of them are multi-specialty hospitals. So that is the brief demography of people who have participated. Now, on the Ayushman Bharat mission, we asked them specifically, what do they think they should do in order of sequence of adoption around these 4 parameters? What they should be doing first to get into the ABDM ecosystem. So most of them have ranked EMR implementation as the first, and then get registered on the HFR and have an ABDM compliant software, and then go around with interoperability. So primarily, EMR implementation is the first thing that is kind of given. But the other things like getting registered on the HFR, having an HPR ID are the building blocks that can be an enabler for digital transformation and help the vision of connected healthcare. Moving on to the next slide, we did ask what.
Joyoti, may I step in here for a minute before you go to the previous slide, please? Thank you.
Yeah, please.
The previous slide. Yes, thank you. So it was actually a very simple question. What we were trying to ask is that whether the EMR implementation is done or not, because if the EMRs aren't in place in the hospital, you can't participate in the ecosystem, right? So if you're not doing a digital prescription, if you don't have lab results digitally available, how do you even start participating? So we wanted to ask indirectly, actually, whether they are ready with the EMR data. And the answer we have is that it looks like 30% have to even take that step forward to be able to complete their EMR implementation. And this is one interesting fact that comes out from this question. Yeah, thank you. Thank you. Sita.
Yes.
Thank you, Jyoti.
So on the benefits, so more than 85% of our respondents feel that ABDM is beneficial. And the most perceived benefits is the clinical outcomes or the longitudinal records that may have. And the least is the financial benefits. Now, what we meant by financial benefits is, having a seamless claims processes in the this thing, and even also having more of billing transparency. But that has been perceived as the least benefit aspect of ABDM. Again, enhanced patient experience is important, where people do think that having good scheduling appointment features digitally and other patient experience KPIs can be enabled digitally. Operational efficiency, what we meant, having better resource utilization within the hospitals, better bed allocations, better OPD and OT utilization. So that came in third. And yes, that's pretty much on the benefits of ABDM.
Yeah, so I think this. Yeah, so this kind of before you go to this slide, yeah.
Sita, go back.
Yeah, thank you. So I mean, it's actually again very obvious, but we were just trying to bring this out. These are profit-oriented hospitals, right? These are private entities. So when they go back to management and say, we want to implement something which will improve things, it's also, I mean, one of the questions asked is, where is the ROI on it, right? And even if we can justify clinical outcomes and better patient experience, we know that ABDM is going to do it. We have to still show that there's also a financial benefit. And I think that perception is not there, that doing ABDM will bring me better financial results. It could be about, whether it helps me acquire more patients, whether it helps me, get more success in, claims, like Joyoti was saying, faster claim settlement. So maybe they're still not able to see those benefits, but they will come eventually. So, but we wanted to reflect what they're saying and not what we want them to believe in. So thank you, Joyoti, for sharing that. Yeah. We can go to the next slide, where we've tried to communicate what would be the benefit if they go for DHIS.
Yeah, so this is one interesting fact that came out from our study. So this is the incentive scheme has been announced by ABDM. This is whatever data we had, we tried to map it to the possible incentive that people may get, or the hospitals facilities may get, if they are compliant with the M3 milestone certified ABDM initiative. So many of our hospitals, almost 45%, like you saw in the previous slides, have an OPD numbers of 1,000 plus per day. So they could stand to win an incentive of around almost 4 to 5 lakhs a month INR. So those with 1,000 plus OPDs per day could get a revenue of 4.5 lakhs, which could be an incentive factor for them to get implemented for other hospitals who have not joined the group to get onto the ecosystem of ABDM. Even the less than 250 hospitals, those who are between 1 and 250, can make around 61,000 approximately. These are all approximate numbers. 61,000 per month.
Yeah, so the conclusion from this is again very obvious that, if you're a smaller hospital, the investment in going for ABDM is not a great ROI, but if you're a little larger place, then the investment in enabling your system to go for ABDM and then capture the DHIS is better, because it's just economy of scale. It's as simple as that. So like Rhea was saying, if it is possible to give them very low cost ways to get onto ABDM and they don't have to spend too much, they would probably be able to gain from the incentives. Otherwise, with the numbers they do, the incentives will not be that good an ROI, is what our understanding is.
Only one point over here is that if a small hospital has lesser number of incentives than a big hospital, but a small hospital would require initial investment also comparatively low than a bigger hospital. So return of investment could be there when
So Vikram, I don't know if the investment is that much lower because see, they need to put in that effort to do that integration, do the EMR implementation. It goes back to the previous question also, right? So they have to get into doing the complete EMR implementation, which we all know is quite an effort for them.
yeah, but that is again an empirical question. We can't say. I think we can't say that for a smaller hospital, the RO, the initial investment is similar to a big hospital. But is what my
Yeah, we are trying to project here. This is not the response from the study. We're just trying to project. Yeah, I agree. I agree
The
with you.
second point is that an hospital is not M1 certified or M2 certified or M3 certified. The software is certified. So
That we are aware.
That's
That we
good.
are,
Yes.
that we are.
just wanted to
Yeah, sure.
clarify that. Yeah.
That we are aware.
Just
But
one
it's-
more.
Sorry,
In
can I just
continuation
come in
to
for the financial bit just in this piece?
Jyoti, just 1 second. Just one question to Vikram on continuation to the same this thing. How fast does this incentive come to the hospital? Because what's the turnaround time? Like today, if I have X number of transactions, what's the turnaround time? Incentive?
Presently, it is about 45 days, and we are trying to make it automated. So the incentives till the month of May 2023, we have disbursed. The June incentives are in progress. So till 30th June, whatever transactions you have done, it takes about presently it is taking about 45 days. So by 15th August, all the incentives for the month of June would come, and
I
we are
think
trying
that is a great tat because
but we are trying to reduce that also. We are trying to integrate it and make it automated. There is a government payment system which is called as the PFMS. We are trying to integrate it through APIs so that the process becomes automated. So we want to make it close to 15 days. So till 30th June, if you do in transactions by 15 July, the money should be in your account.
that's a great
PMFS's APIs are very primitive, but they don't allow too much of a flexibility in terms of third-party integrations. And that's been my experience, Vikram.
We are trying hard.
Rhea had some comment. Yeah, Rhea, go
Thank you,
ahead.
Bharat sir. Thank you. Just wanted to come in because I know that was an important piece on the financial incentives or just the financial aspect of joining ABDM. I just wanted to shift some perspective that I think what ABDM is trying to do is change the healthcare ecosystem in a long-term game, right? And while these incentive schemes will exist to kind of catapult and accelerate that adoption, but to also take a step back and look at what ABDM is offering as a whole. So, for example, with UHI, if you are onto the UHI network, essentially that is going to increase access for a lot more citizens, which will contribute to more services that a hospital will have to fulfill, right? So that they're going to be more discoverable. They're going to get more bookings, more services, as more and more citizens can start availing digital health services, right? So I think that in itself is a very good incentive that we've seen at least some of the initial players respond to, saying, hey, my market size is increasing as a whole, right? The moment everyone's coming onto the platform, it's great for me because my market is increasing and I have more patients to serve and I have more partners that I can collaborate with, right? That is
Absolutely. And that is what we are trying to do at HCHE. We are trying to evangelize exactly this, but be on my side when I make this presentation to several hospitals. It's not convincing them that this is going to happen.
I understand. We've also been trying to solve for this for a year and trying to bring that shift.
Yeah.
And the second bit is also, I think, which I imagine will get more immediate responses also the moment HCX is out, right? HCX is going to directly drop down very high, that hospitals are paying very high costs for those filing of claims with different insurance companies and all of that, right? So
Definitely.
Once HCX is there, that will bring down the immediate cost for that as well.
Perfect,
so I think those two are very
Perfect, Rhea. So we'll do the survey again after HCX adoption, and we'll ask if the financial should be the number one benefit perceived. But right now, it is not perceived, is what we're trying to say. Yeah. So Joyoti, please go ahead. See, this is just current perceptions. We are not, we're letting the numbers speak for themselves on this. Yeah, Joyoti, please go ahead.
Yeah. Around the risks, 60% of them feel that there is a risk associated, and the major risk that people see is data security and privacy. Another risk that they see is loss of patients to competitors. Now, this is something we need to ponder around. And the medical legal risk, mandatory participation in ABDM, and lack of resources are relatively, not very strong risks. So that is something.
These could be misconceptions, but this is what our respondents stated at risk. Some of these could be, I think the data security and privacy is a total misconception. The way ABDM is structured, you should be more assured that there is less risk. But somehow our respondents, if you see, 46% perceived a higher risk with ABDM on data security and privacy.
So this is because of the lack of awareness what ABDM is doing. Probably if we have more awareness, this perception may change.
Correct.
Yes.
Sorry,
yes.
go ahead. Sorry.
Yeah, that's fine.
I think I just wanted to say one thing on the last slide. I think it will help us also. This is very, very insightful. I think it will also help us if you can tell us something more as to what was spoken exactly on data security and privacy, so that our awareness around those issues that have been spoken. In general, we will, I agree that it might be due to misconception, but if there is something more we would like to.
Yes, Vikram, we are doing a follow-up interview with people on this.
So, and second is loss of patients to competitors. I think this customer retention has come up again and again as a roadblock. We have been trying to have a discussion as to the resource-rich hospitals, the Fortis, the Max, Narayana Hridayalaya, Manipal hospitals, Wokhad, Girish ji is here. We are trying to, and Apollo, we are trying to reach out to them, say that please, now that you have resources, now that you are M1, M2, M3 enabled, at least use them. This risk, due to this risk, they are not coming. But I just wanted to ask the panel and also everybody. I have this polythene and I have the report of SRL. I can go to anywhere and show, or if I have the prescription of Apollo, I can go to Narayana right now also. I mean, how does making it digital or how does making it ABDM is a loss to competitor?
So Vikram, we'll answer, Sri Vikramji, we'll answer this in the follow-up to this survey. This is good. We are going to do deep dive interviews with a smaller set of people to get these answers. But what we understand from the survey is that they've definitely on their own come up with this, the statement. It could be just
you had not given them 1, 2, 3, 4, 5. They have written it on their own. Oh, is it?
Yes.
No. So we've done a preliminary study, and in which we had got multiple responses, and then we coded those responses. So we've done a preliminary research with a smaller questionnaire where about 35 people had responded, and in these options had come up, and then we give them as coded responses because then we could analyze it better. So that's why we had coded it. But initially they came in as direct responses for people. So we will dig into this further and come back in our continuation of the study. Yeah,
It will be very helpful.
Thank you. Joyoti, please go ahead.
Yeah, moving on to the leadership and organizational commitment. Sita, if you move on to the next slide. So we had asked people to rate themselves. It was a self-assessment, and we had asked them to rate themselves on the digitization that they are currently at. So we had used the bullet points on the right. So basically, if they are digitally advanced in any 2 or less than 2, then they are digitally competent in any 2 or less than 2. then they would have rated themselves as less than or equal to 20%. And if there are 3 or 4 of these above the bulleted points are they are digitized, then they would rate them as between 20 to 40%, and so on and so forth. So we have 10 bullet points, and that's how most of them rated themselves as self-rated themselves, and 35% of the hospitals have self-rated themselves as 40 to 60% now, and they have a highly optimistic expectation in the next 2 years that they would get to 80 to 100% in the next 2 years. So the average present digitization is 56%, and in the next 2 years, they hope to get to 81%. So there is a good amount of optimization.
Yeah, so this is something that is quite remarkable, that although there are some misconceptions about ABDM, there is no misconception or hesitation about digitization. There is a lot of optimism about what digitization can do for the hospitals, and they're very keen to go ahead in that journey. That is the perception we have for the study, and we will again be digging more into it. What is the motivation to go for this digitization, higher amount of digitization? Yeah.
Here is some interesting fact on the budgets allocated. So if you see around just 2% of the people, less than 2% of the people, annual turnover, based on the annual turnover, they are spending less than 2% of their IT budget on digitization efforts. Of that, only about 30%, 38% are in this 2%, less than 2% bracket. The others are spending much lesser. And of this 38%, also only 18% are spending on digital health solutions. So this overall IT budget includes the hardware, software, and everything under the sun. So while we are expecting to leap forward in the digitization from 40% to 80% to 80 to 100%, we need to make sure that the budgets are allocated to IT going forward. And we hope to see that the 2%, less than 2% increases, the small numbers we have over here increases over the next 2 years.
Yeah, so on behalf of all the CIOs, I would say that if the leadership is motivated to open the purse strings, then only that optimistic level of digitization can happen. And I think we all should work towards it as an ecosystem. So let's just go ahead to the next point, Joyoti. Thanks.
Yeah. Innovation. Yeah. Sita, can you move ahead? Yeah. So most of them, again, there's not much of innovation happening. Only 61% have responded that they have not deployed any kind of emerging technologies. Those that have deployed are IoT and IoMT, artificial intelligence and virtual reality. We did see IoT devices being used a lot by hospitals during the COVID pandemic, but we are also seeing an interest in artificial intelligence over the past few years. Yeah, any thoughts around that, Bharat?
Oh, keep going, Sita. I think we're running short of time. I think most of the facts are on the slides. Just please go ahead.
Yes, yes. So mobile apps, we are seeing a large use of mobile apps. 20% of the response don't have any mobile application, and then 30% of them are using patient apps, which we are actually seeing most of the larger hospitals do have patient apps. Fortis, Apollo, I think most of them have patient apps. And 30% of the hospitals also have doctors' app. What we are seeing is nurses' apps are not really large. I think that could be an important area because a lot of the ongoing care can be done through nurses' apps. So that is an area where definitely there is a requirement. And there are other apps.
Hello.
Labs that are also being used by many of the hospitals. We can move ahead. This is a list of the HIS and EMR applications. So we have a highly fragmented, and most of these EMRs are hosted on premise, very few on cloud. And on the right side, we have the EMR applications of the people who have taken the HIS and HIS applications of the people who have responded to our survey.
Do we want to run a poll here quickly?
Yeah.
Sita, do you, Jyoti, maybe Sita, you can just run a poll there on the cloud part. So what
We can have a poll question come up.
yeah, poll question come up. So, this thing is that, is it really important to be on cloud for participation in ABDM? Can you bring that question up, Sita, please?
Yes.
So that the audience can participate. Okay, this is also a relevant one. Let's keep this open for polling. Are you getting responses, Sita?
Yes, sir. Yes.
Bharat sir, the panelists cannot vote, is it?
Panelists can
No,
speak now, so they don't need to vote.
No, I can't speak out my answer.
Wanted the audience to have a way to participate also. Yes, Sita, you can close it now, I think.
Yeah. And Bharat, we are running against time. So
Yeah. We'll move
I'll
fast.
be quick. I'll be quick.
Core HIS or EMR with few APIs and integration is best. That is the most rated option.
Okay, what are the numbers?
56% rate that core HIS or EMR with few APIs or integration is best. While
You want to put that
35
up?
Okay.
Okay.
third
So the
approach with
preference
API
is
stack.
for the core HIS to be with least API integration. That's great to know. Thank you. Yeah, please go ahead. Joyoti, please go ahead.
Yeah, so the digital capture of data. So what we did over here, we asked our respondents to which departments they are using, irrespective of clinical or non-clinical. And we found that 95% have responded that they are using digital capture of data in the outpatient or OPD. It looks like it's mostly in the billing areas that they are using the digitization in the outpatient. However, in the other departments like labs and radiology and inpatient, they are using digital recording of data. They are using some system to capture the data. ICU is falling back. Even so, primarily the people who have responded are the hospitals who are technologically advanced, and only 35% of them are capturing ICU data digitally.
Go ahead, please.
That is App integrations, we found that APIs are the most used method of integrating with other apps. More than half of our respondents have less than 5 applications integrated with the HIS, 56% exactly. And HL7 technologies are not being used primarily because most of them are either legacy systems or not HL7 enabled. That could be one possibility. And 40% are using APIs for interoperability, followed by database level integrations, which is around 35%.
So I want to make a comment on this one based on my experience and this data and the poll as well. See, we talk about so many digital health startups that have come up. But when you go to the hospitals, they prefer to have a core product which takes care of most of their needs. And when so many of these digital health products come with small features that they want to make hospitals use, they're not able to get enough adoption. So because all of those then need to be integrated with the hospital's core system. And frankly, I haven't understood how ABDM solves that problem, because that is not an interoperability problem, it's an integration problem. And I find that a lot of startups that are trying to bring in innovation, and HCHE supports innovative startups, we're finding it very difficult for them to get higher adoption, because the hospitals prefer a core integrated system. Unfortunately, the core integrated systems that exist are legacy. They're mostly on client server, they're mostly on premise. So, the level of innovation and things that are possible on them are limited. So this is sort of conundrum we're finding from the data as well as from my, observations of the industry. Yeah. Thank you. Yeah, go ahead, please, Joyoti.
Yeah. Again, on the data repository, most of them, 63% have a data repository. They are storing data in some kind of data lake, BI or data mesh, some BI tools. Others are on-premise or using legacy systems to within their EMR itself. They are storing their data. Doctor, yeah, move on to the next one. Barcode technologies, asset identification, 85% of them using some barcode technology, primarily in the lab setup, either a barcode or a QR code or an RFID. And IPDs, only about 22% of them are using some kind of barcode technology, which is kind of what we are really seeing in.
Which is very important because it's a great opportunity for digital health ID to then be, incorporated into the barcodes. I think that will really help a lot if that bridge is enabled. But there could be some issues because if I have multiple digital health IDs, then which one do I translate to the barcode within the hospital? So the hospital will continue to use their internal ID to do that. So that's a bit of a bridge to cross there. Yeah, thank you.
So the collaboration part is interesting. So we have home sample collection, ambulance services and all. These are being collaborated with digital health tools. And most of the hospitals are doing some kind of collaboration on these areas. So home sample collection is of course very common. Ambulance services, most of the major labs have home sample facilities by the click of a button. Ambulance services, medicine home delivery, and home care services are also available with the digital health solutions. Now, around the pharma or medical device collaboration, 35% of the respondents have collaborated that they are collaborating with pharma and medical device companies. Majority are still not doing that.
Okay, so there's an interesting thing there. If you go to the slide back, see. The thing is that consumerization of healthcare is a very important consideration for hospitals that are private. So if you look at these collaborations that have been taken up, those are the ones which are consumer driven, not by a mandate or not by you should do this. These will do because there is a consumer thing that I want lab collection at home. I want access to ambulance. I want medicine home delivery. These things motivate hospitals to participate in the ecosystem because they can't miss out on these things. Otherwise, they'll lose their customers who come to the hospitals and don't go to the lab and don't go to the pharmacy. So they have to provide the same thing that digital players do. So they're getting driven by consumerism towards digital. And we can see that in the answers because ideally for better healthcare, you should have use of IoT and personal health apps, but there's not a clear consumer angle there yet. So I'm just trying to project from the data here. Yeah, thank you. Go ahead, please, Joyoti. Yeah, Joyoti, please go ahead.
Moving on. Yeah, Sita, can you move on to the next slide? Yeah, therapeutic apps. Again, we have a lot of digital therapeutic companies that have come into play recently, especially with diabetes. However, only around 8% of respondents have collaborated with these digital therapeutic apps, and most of them are in the areas. Out of these 8% who have, most of them are in the areas of diabetes, hypertension, and mental health. However, many of them are still planning to go ahead with diabetes and hypertension collaboration, followed by mental health.
So it's a very nascent stage right now in terms of adoption of digital therapeutics is what the data is showing us. The technical capability and the vendors are there, but I think adoption is still at a very early stage.
What is a digital therapeutic app? For example, diabetes. What is an example?
So a blood glucose monitoring device at home and an app which has a coach along with it, just like.
Got it.
Yeah.
Yeah.
We have Beto and we have several startups, Fitterfly and all these kinds of people. And Wealthy had tried to do it earlier. So, if they work with the hospitals, then, they can collaborate and reach out to their patients. But that collaboration is not, happening that much right now.
Yeah, moving on to the patient engagement capabilities, like online appointments has a good number of respondents. 90% of the hospitals do have online appointment and scheduling and patient feedback capabilities. And other patient engagement, like patient engagement and patient communication, those are smaller numbers. But it's interesting to note that most hospitals have gone ahead and have installed some kind of patient engagement digital devices to go ahead in the game. Yeah, let's move on. Patient experience KPIs, these are being measured by some of the hospitals, like discharge time, OPD waiting time, patient satisfaction and NPS scores, waiting time for diagnostics, billing errors and claim settlement errors. These are being measured as KPIs. Discharge time is the most commonly one KPI measured, which is at about 71% by these hospitals that we have surveyed. Privacy and security, 80% of the hospitals have no certification for their systems on privacy and security, and those that who have are certified by ISO 27001. Bharat, any closing comments?
So, but technically we are out of time. We would like to share.
Sorry, Bharat. Joy, just go back to the last slide, please. Just go back to the last slide. Yeah. While 80% have said that there is no certification for their privacy, security, and things like that, I am actually a little surprised with this outcome where they're saying that they are 27,001 or HIPAA certified. I would probably like to do a little more deep dive into this to understand what do they mean by I'm HIPAA certified.
Sir, actually it's HIPAA or ISO 27001.
Agreed,
Yeah.
Sita, agreed. I'm not saying no to it, but then if somebody says I'm HIPAA certified in India, not very many. So I want to understand what's happening, how they're doing it.
We will dig deeper into this. There could be a misunderstanding of HIPAA certification. They may be using some software which is HIPAA compliant.
So Bharat, this is what I was thinking. We have about 45, 48 respondents, or a little around 50 respondents who had responded to this survey, right?
Right.
Now with the brief and the background, what we've got from Vikram and the team here, do you think we should revisit this and look at if the team wants to redo their survey again? 1, 2, we may even look at asking a lot more people, because we have about 95, 98 people, and that's a wonderful, wonderful number to have on a Saturday morning on the webinar. So if more and more people want to take up the survey, the report becomes a little more meaningful and comprehensive, but then with a dedicated and a defined timeline. If we want to do that, we can take a call and then do it. I'm good with it.
Yeah, sure, Girish. Thanks for the support from CHiME and the ongoing support from CHiME for all this time. As you know, our original mandate was to try and reach 150 respondents. So we will continue to make that coverage, because once we have that coverage, we'll be able to do a segmentation exercise and be able to say, what's depending on the number of beds, what is the level of digitization. We couldn't do this segmentation in this study right now because the number of responses are lower. But like Shri Vikramji also requested that we should go into deep dive, we should do interviews and get explanations about some of these points. That is very much planned, and that we will definitely do amongst these respondents and do a deep dive and get those, deeper validation as well as deeper insights into the topics that we've covered.
Can we quickly run the poll questions as well? We had a couple of poll questions for the audience.
Sure. We can run a few of those poll questions quickly. In fact, one is about the certification. So let's take the audience's view on that. So Sita, can you run some of the poll questions, please?
Yes, sir. Privacy and security certifications.
Please.
Yeah.
Give it about a minute. It's a very simple question. So.
Okay. Most of them tend to answer that certifications are essential.
Okay, then there's a large number of them who need to go for certification, and if the government supports the certification process, that'll be great. I think the software needs to be certified as well as the organization needs to be certified, right, Girish? Girish Kulkarni, when we go for certification, both the product and the organization needs to be certified, right?
Yeah.
So I think we should encourage from CHiME and from NHA, we should encourage people to go for ISO 7001 and, for the IT systems, because anyway, they have on-prem systems, so those should be certified. Yeah, a couple of other questions, Sita, if you could just run a couple of other questions.
Yes, sir.
Yeah, this will not take long. We just have a few questions.
Yeah. You choose, Sita, no problem.
Sir, what about budget allocation? Shall we go?
Yes.
Yeah, you choose, Sita. Just go ahead and ask 2 or 3 questions. So,
Have the budget allocated for digital gone up over previous years, especially after COVID? Okay. But okay. There is a tight competition, I must say. Few say that like gone up significantly, while almost equal 52 and 48%. 48% say that more or less same as earlier.
if you close the survey, the results will come on the screen. There's a close button. If you just close the survey, it will come on the screen. The results.
It's 50-50 now.
Okay. No, if you stop the survey, the results will come on the screen.
Okay, so share results.
Bharat, I think we
Yeah.
are almost at the
Yeah.
end of the.
No, but we can all
Just-
see the results here now.
Yeah.
Are you able to see this?
Yes.
Yes.
So 50% say it's almost the same budget. That is quite a thing. One more question, last one.
Yeah.
Yeah. Cloud wala puch lo, Sita. If you could get the cloud question. Or just pick any one more question.
Should I go for DHIS benefits?
Yes.
Yeah, please. Yes, Sita, I think you can close them.
Close it.
We have type.
Not bad. 56% believe it will motivate. So that's a good sign.
Yeah, Sita, I want you to add one last question and ask the participants how many of you have paid the child membership fees for the current year?
We haven't.
It's all about finances, Bharat. All about finances.
We'll do that later.
Do we need a
Thank
feedback
you.
on webinar?
Thank you.
Yeah.
Thank you.
So we definitely want to follow up with more details, like I said, and more coverage. And once again, support from CHiME. Thank you so much for the support. And thanks the volunteers who worked with me on this project, including some of the students from the ISS who had participated also on the study with our team. And of course, thank you so much, especially Girish Koppar. Thank you so much for your encouragement and support throughout. And of course, Girish Kulkarni for initiating this and helping us, keeping me always motivated to continue the study at times when I said, give up, yaar, response nahi aane wale, and all that. Because the questionnaire was long. It was taking people 15-20 minutes to fill. And it was difficult to get people to fill that. But we wanted to bring out a rich response. So,
Bharat, I'm a consultant, so I can only tell people how to do it. But I still need people like you who can actually do it.
Thank you so much. Thank to the entire CHiME board for it. Thanks, Arvind. Any closing comments from Shri Vikram ji on how you feel about these survey? And I don't know if we want to enable some of the participants to ask questions online. I could do that.
Yeah, Bharat, there are a lot of questions that will be asked. There has to be a follow-up session and with a feedback form, because people who couldn't ask and have left may have some questions. So let's have one feedback mechanism, and we'll see if how many people want one more follow-up questions, so that all the misconceptions are disappeared, and this entire ABDM has some better momentum to go. So let's have that feedback. I think most of them will say yes. So
we'll do that. And we'll gather all the questions and compile them as well. Whatever has been asked.
Vikram, are we good for a follow-up session? How was your team aligned, Vikram, Rhea? So I'm sure a lot of people have questions, and it'll really help the cause to have the initiative going strong. So we can work as a team and then discuss offline how to work that.
Yeah.
Arvind, any thoughts on that?
Definitely yes, in terms of follow-ups, and probably what we can do is enable a feedback, get people to ask the questions, so that we can discuss it with the NHA team and come prepared with answers, rather than off the cuff question and answer session that could be a little more structured, and then we can leave it to an open thing. So let's do a follow-up on additional questions or concerns that people would have, that we can help us mitigate.
What we can also do is we can do an open house, only Q&A. So next session would be only Q&A. Anybody wants to ask anything for as long as they want, all their answers.
That's a great point.
Yeah, maybe we can collate all the questions, because an open house may go in any direction. Let's collate all the questions, and we can have a structured open house. So that will be more effective.
That's great.
No, Girish. Open house will not go in any direction.
No
open house. I will keep my UPI on. Only after I get the payment and it hits my account, I will open the mic for them to speak and ask.
No. So thank you all for taking time out on a Saturday. Thank you all of the audience. We structured this as a webinar because the meeting had a capacity of 100, so that's why a lot of people are not able to participate on video. But for the hospitals that are members of CHiME, along with CHiME, we'll do a separate session where all of them can be in a meeting setup. All right. So Vikramji, any parting comments from your side? Then we can close.
No, I think the study was very insightful. Many of the things we already knew, and many of the things we would want to know more. But I think it is about the value proposition of digital health. Digital health, everybody is interested. They want to do digital health. But how does ABDM make it more attractive, make it more useful for the hospitals? This is a direction in which we have to think, and we have to provide more value. We have to give more value proposition to the hospitals. I was just checking that out of 28 crore records that we have linked with ABHA, only 6 lakhs have been linked by private providers. So mostly it is government driven, and the private hospital which is doing the maximum number of transactions is a small clinic here in New Delhi, which is a Panchsheel Orthopedic. So there are a lot of good examples of hospitals who are actually doing or using ABDM enabled, and maybe if we can study them in more detail, then we'll come to know. But these studies are very important, and they give us good food for thought. Yeah.
Thank you. And before we wind up and before Koppar closes the session, a quick 1 minute. We had about 50 plus questions which were there on the Q&A panel, and there were a lot of questions which the panelists were also asking Vikram and team here. I think most of them were addressed. I'm not sure whether if the responses were completely satisfactory, or would it need an additional debate and a discussion with you. We are you're most open and welcome to reach out to us, ask these questions, and we will try to revert as early as possible, as as detailed as possible. We will do that. We probably will consolidate all these and then circulate it on the group also, so that everybody gets to benefit with the questions which have been asked by the others, right? We'll do that. There can be some of these questions which did not go answered today. Believe us, it was not intentional, because it's difficult to speak here, to focus here, and also keep typing. Our apologies, but then I'm sure it's all a part of the game. But we will come back and then close all this with you. Thank you. Girish, all yours.
Yeah. Thank you once again on behalf of CHiME. Thank you, Vikram, Rhea, for coming up at such a short notice. Bharat and team, Joyoti and Sita, for having this survey done. And a big thank you to all the participants who are still from 11:30. I know most of them are working, because a hospital works 6 days a week. They could still manage to hold on. So thank you once again. And as discussed, we'll definitely have a follow-up session. We'll send you a feedback form. Please do reply. What are your expectations? What was missed? How can we do it better? And etc. etc. So once again, thank you all and have a great weekend.
Thank you. Thank you so much.
Thanks.